Welcome back to the deep dive. Today, we're on a pretty critical mission, synthesizing the absolute highest yield material from the MKSAP 17 nephrology sources.
Right.
Our goal is to build a rapid but still comprehensive blueprint of core renal evaluation and management, something specifically for medical learners, young professionals, and really anyone who needs to get a handle on this stuff quickly.
That's the plan. We're really trying to distill the most clinically relevant insights. It's not just about facts, it's about diagnostic flow and those high-value care HVC recommendations that, actually change outcomes.
So we're covering everything from basic kidney function, electrolytes, all the way to CKD and AKI.
Exactly. All the major domains.
Excellent. Let's jump right in then. Let's start with that foundation. How do we even assess kidney function? What really defines how severe the impairment is?
Well, the best single index we have for that is the glomerular filtration rate, the GFR. But, and this is a huge but, a patient can have profound structural kidney damage, like major proteinuria, while their GFR is still totally in the normal range.
How does that happen?
It's something called compensatory hypertrophy. The remaining healthy nephrons just start working double time to pick up the slack. So the kidney is already diseased, but the function numbers, they mask the severity.
And that hidden damage, I assume, brings us to the limitations of our most common tool, serum creatinine. We use it every single day, but it's known for overestimating the true GFR. Why is that?
It's because creatinine isn't just filtered, it's also actively secreted by the proximal tubule. Now, when kidney function is normal, that's a small amount.
Okay.
But as function declines, especially in advanced CKD, that tubular secretion can account for up to 50% of the total creatinine excretion.
50%.
Yeah, 50%. So if half of what you're measuring is being secreted, your calculation is going to look a lot better than the actual GFR.
I think the most important thing for listeners to grasp about creatinine is that nonlinear relationship with GFR. Can you maybe walk us through that?
This is such a key clinical insight. So imagine a patient's creatinine goes from, say, 0.8 to just 1.2. That tiny, seemingly harmless bump. Right.
Actually reflects a massive drop in GFR, sometimes up to 40 or 50 milliln. Most of the kidney function is lost when creatinine is still barely elevated.
So a big jump when the creatinine is already high, like from 3.0 to 4.5, is actually less of a functional drop.
Exactly. The lesson is small changes in the normal range are way more significant clinically than large changes in the abnormal range.
That really reframes how we should be looking at those labs. Now, what about BUN? We often check it, but it seems like it's a pretty poor marker.
It is. It's just influenced by too many other things. Dietary protein, fluid status, a GI bleed. It's too variable. It only really becomes useful when we're looking at very, very low function, like GFRs below 15, to track progression towards dialysis.
So we rely on estimation equations like MDRD and CKD-EPI. What's the big caution there?
Well, they're generally better than a 24-hour urine collection, which people are just notoriously bad at doing correctly. But the MDRD equation often underestimates GFR when the true value is over 60.
And that leads to labs just reporting 60, right?
Exactly, which is a huge clinical blind spot. Wait, that feels like it could be actively dangerous. How often are we masking damage with that cutoff?
I mean, think about it. If a patient has an eGFR of 75, but they have significant proteinuria, that's a clear sign of structural damage. Reporting 60 just completely fails to signal that pathology. That's why you have to look at your analysis, too.
Okay, speaking of urinalysis, let's hit those basics. Specific gravity of 1.010 is about isosmolar, right? Around 300 mL m/kg.
That's right.
So what are the dipstick pitfalls we absolutely have to know?
There are two critical ones. First, ketones. The dipstick only detects acetoacetate. It does not detect beta-hydroxybutyrate.
And that's the main ketone in DKA.
It is. So you can have a patient in severe diabetic ketoacidosis, and the dipstick might read negative for ketones, a really devastating false negative.
Wow. Okay, and what about blood on the dipstick?
The dipstick detects peroxidase activity. So that could be RBCs, but it could also be free hemoglobin or myoglobin. You always have to confirm with microscopy. And remember, high doses of vitamin C ascorbic acid can cause a false negative.
And if we do see RBCs under the scope, their shape is everything.
Absolutely. Are they isomorphic, all uniform, suggesting a source like a stone or a tumor downstream? Or are they dysmorphic, all misshapen, maybe with casts? That points you straight to the glomerulus.
And for proteinuria, we're not doing 24-hour collections anymore if we can help it.
No, high-value care is using a spot urine protein to creatinine ratio. Normal is less than 150 milligrams. The number you have to burn into your brain is nephrotic range proteinuria, greater than 3,500 milligrams. That much protein loss almost always means a primary glomerular disease.
Okay, so we know how to measure the damage. Let's talk about fixing it. Fluids, electrolytes, acid base. Starting with hyponatremia.
The absolute first step before you even think about volume status is to measure the plasma osmolality. You have to exclude hyperosmolar hyponatremia.
The classic example being hyperglycemia.
Exactly. And you have to remember the rule. Serum sodium drops by about 1.6 for every 100 that glucose is above 100. If you don't correct for that, you'll mismanage the patient entirely.
So once we confirm it's truly hypotonic hyponatremia, the next pivot is the urine osmolality.
Yes. If the urine osmolality is super low, like less than 100, the kidney is doing its job. It's suppressed ADH and is dumping free water. You see that in primary polydipsia.
But if it's high,
If it's over 100, then ADH is in the driver's seat. That could be inappropriate like in SIADH or appropriate like in hypovolemia.
and for managing chronic hyponatremia, what's the one rule we can never, ever break?
The HVC recommendation is rigid on this. You must correct it slowly, over 48 to 72 hours. Correcting too fast causes osmotic demyelination syndrome, or ODS, which is a catastrophic neurologic injury.
A completely preventable one.
Completely. The risk from ODS is way higher than the risk from the chronic hyponatremia itself.
Okay, shifting gears to potassium. When do symptoms of hypokalemia usually start?
Generally, muscle weakness and EKG changes start to show up when potassium drops below 3.0. The risk of rhabdomyolysis gets really serious when it dips below 2.5.
And how do we figure out where it's being lost from?
You check the urine. If the urine potassium is 20 AREQ24 or more, you've got urinary losses. Think diuretics or mineralocorticoid excess.
Quick question on phosphate. What's the usual cause of hyperphosphatemia?
Almost always, it's just a failure to excrete it because of reduced kidney function. So CKD or AKI, management is all about dietary restriction and phosphate binders.
Okay, let's tackle metabolic acidosis. First step is always the anion gap.
Always. If the anion gap is high, you're looking for an added acid. The most common one by far is lactic acidosis. You treat the underlying cause, and you only give bicarb if the pH is profoundly low, like below 7.1.
The tricky part is telling that apart from toxic alcohols. What's the red flag there?
You should suspect toxic alcohols like ethylene glycol or methanol if you have a high AG acidosis plus a high plasma osmol gap, usually greater than 10.
And why does that gap happen?
It's because things like ethylene glycol are unmeasured osmols. They contribute to the measured osmolality, but not the calculated one. That gap is the toxin. And remember, ethylene glycol poisoning specifically causes AKI from calcium oxalate crystals in the tubules.
Right. Okay, what about a normal anion gap metabolic acidosis, or NAGMA? How do we know if the kidney is the problem?
With NAGMA, you check the urine anion gap. This tells you if the kidney is doing its job of excreting acid.
And what does a positive urine AG mean?
This is key. A markedly positive urine AG suggests the kidney is failing to acidify the urine. It can't excrete acid properly. This points you directly to a renal tubular acidosis, or RTA.
Can you give us a quick example?
Sure. Type 2, or proximal RTA, is a defect in reabsorbing bicarbonate. It's the classic finding in Fanconi syndrome, which is this generalized tubular defect where you lose not just bicarb, but also phosphate, glucose, and amino acids in the urine. That whole cluster is your diagnostic key.
Got it. Let's move into some long-term management topics, starting with hypertension.
Hypertension is, well, it's just devastating. It's the single strongest risk factor for both hemorrhagic and ischemic stroke. And it just relentlessly accelerates the progression of kidney failure.
So for initial treatment, what does high-value care prioritize?
Two things. First, lifestyle modifications for every single patient. They can be as effective as a low-dose medication. Second, combining two moderate-dose drugs is often better than maxing out one agent. Better control, fewer side effects.
And do we need an echo on every new hypertensive patient?
No, absolutely not. Echocardiography is not for routine diagnosis. You save it for patients who have known heart disease, a new LBBB on their EKG, or if you're really suspicious of something like white coat hypertension.
Okay, shifting to chronic kidney disease, CKD.
Yeah.
How do we define and stage it now?
CKD is defined as an eGFR below 60, or markers of kidney damage, like albuminuria, that persist for more than 3 months. And staging requires both the GFR category G1 to G5 and the albuminuria category A1 to A3. You need both for prognosis.
And a major complication is anemia. Why is iron so important in managing that?
Well, the anemia is typically normocytic, a diagnosis of exclusion. But the most common reason a patient on ESAs, or erythropoiesis-stimulating agents, doesn't respond is simply iron deficiency.
Which brings us to an HVC point, right?
Yes. For hemodialysis patients, intravenous iron is preferred over oral iron. Uremia can impair gut absorption, so IV is just more reliable for replenishing those stores.
And what about the metabolic acidosis that comes with CKD?
We treat it, we use oral alkali, like sodium bicarbonate, to keep the serum bicarb in the normal range. And this is high value because treating the acidosis has been shown to actually slow the progression of the CKD itself. It's proactive.
Let's wrap up CKD with mineral and bone disorder. What's the main goal in non-dialysis patients?
The primary goal for stages G3 to G5 is normalizing PTH. Start simply, correct vitamin D deficiency, normalize calcium and phosphate. If PTH is still high after that, then you bring in calcitriol. If it becomes completely unresponsive, that's tertiary hyperparathyroidism, and that patient needs a parathyroidectomy.
Okay, let's pivot to acute threats now. Starting with acute kidney injury, or AKI, what's the definition we need to know?
The KDI-GO criteria define API as a rapid change, a creatinine increase of 0.3 or more in 48 hours, or an increase to 1.5 times baseline within 7 days.
And in terms of intrinsic causes, how do we distinguish something like atherosclerotic disease?
So ATN is usually ischemic or from a toxin, but atherosclerotic disease is different. It happens days to weeks after a vascular procedure. The clues are eosinophilia, low complement, and this mottled skin pattern called levato reticularis. It's a much slower burn.
And what about AKI from crystals blocking the tubules?
Right. Think of urate crystals in tumor lysis syndrome. Or going back to our earlier discussion, calcium oxalate crystals and ethylene glycol poisoning. Those are very specific treatable causes.
Let's talk prevention. Two big ones: contrast-induced nephropathy and gadolinium risk.
For CIN, the best thing is prevention with intravenous hydration isoconic saline or bicarb solutions. That's better than N-acetylcysteine. For gadolinium, the HVC recommendation is a hard rule. Avoid MRI contrast if the eGFR is below 30, period. The risk of nephrogenic systemic fibrosis is just too high.
Briefly, glomerular diseases. Why is nephrotic syndrome linked to blood clots?
It's an acquired prothrombotic state. You're losing your natural anticoagulants like protein C and S in the urine. So prophylactic anticoagulation might be needed, especially if the serum albumin gets very low, like below 2.0.
And finally, chronic tubulointerstitial disease. What does that look like?
You should think about it in patients with slowly progressive CKD, a bland urine sediment, so no casts or weird cells, and proteinuria that's non-nephrotic. The diagnosis really hinges on a meticulous medication review. Think NSAIDs, PPIs, lithium.
Last topic, kidney stones. What's the HVC approach to imaging?
So non-contrast CT has been the standard, but we're leaning more towards ultrasound as the first test now. It's cheaper, no radiation, and it's the go-to for pregnant patients.
And management often comes down to size, doesn't it?
It does. Conservative management, pain control, hydration, maybe an alpha blocker, is totally appropriate for stones 10 millimeters or smaller, as long as there's no infection or obstruction.
And if we know the stone type?
That helps a lot. For uric acid stones, you want to alkalinize the urine to dissolve them. For calcium stones, the most common type, we use thiazide diuretics to reduce calcium excretion. And a low-sodium diet is key because it actually enhances the effect of the thiazide.
This has been an incredible synthesis. We've gone from the subtleties of creatinine all the way to the cornerstones of managing CKD and AKI.
I think the big takeaway for you, the learner, is how interconnected this all is. You know, how type 2 RTA connects to Fanconi syndrome, how eGFR dictates the safety of contrast. Putting those pathways together is what takes you from just memorizing facts to true clinical thinking.
Absolutely. To test that ability to synthesize, we've got a final review exercise for you. A 65-year-old patient with cirrhosis presents with hyponatremia. The labs show plasma No 125, plasma osmolality 255, urine osmolality 350, and urine 15.
Okay, think about this in two parts. First, what's the patient's likely volume status based on that history and that low urine sodium? And which major category of hypotonic hyponatremia does this fall into?
And the second part.
Second, if this same patient then developed a normal anion gap metabolic acidosis, what RTA subtype would you suspect if their urine anion gap was markedly positive? Think about the fluid dynamics and liver failure and how the kidney handles acid.
That's your challenge. A great way to integrate these concepts. Until the next deep dive, keep questioning the plasma osmolality and don't forget that albuminuria.